Thank you.
I invite Dr. Praveen Gupta. Contraception in obesity is her topic. Dr. Praveen.
Yes, ma'am. Can I start sharing my screen?
Yes, please.
First of all, at the onset, I would like to thank Delhi Gynecologist Forum and Dr. Sharda Jain ma'am for inviting me to speak on this topic, contraception in obesity.
Hello.
Good afternoon, everyone. Am I audible?
Yes.
Hello.
Yes.
Thank you, ma'am. Good afternoon, everyone. My topic is contraception in obesity. Currently, around 63% of women in the world are obese or overweight. The unintended pregnancy of concern in patients with raised BMI or obesity because unintended pregnancy is associated with maternal complications like gestational diabetes, gestational hypertension, preeclampsia, increased rate of cesarean sections and PPH, whereas fetal complications or fetal risks are like macrosomia, growth retardation, stillbirths, cardiac anomalies. Additionally, infants born to these mothers of raised BMI are at a lifelong risk of long-term sequelae of childhood obesity and type 2 diabetes. So the issue of family planning should be addressed adequately in these patients. The main primary safety concern of issues are that it is exogenous administration of estrogen is associated with increased in cardiovascular risks like venous thromboembolism, myocardial infarction, or acute ischemic stroke. Hence, we have to tread with caution in prescribing contraceptives to this patient. The baseline risk of venous thromboembolism is around twofold in patients with raised BMI compared to patients with normal weight. Now, the definition of BMI, according to the WHO, is, as we all know, it is measured in kg per meter square. Normal range is 18.5 to 24.9. Overweight is 25 to 29.9 kg per meter square. Obesity class 1 is 30 to 34.9 kg per meter square. Obesity class 2 is 35 to 39.9 kg per meter square. And morbid obesity is more than 40. And by the waist circumference, in any waist circumference more than 88 centimeters is associated with an increased disease risk. There are two types of obesity, apple versus pear. We all know apple type of obesity is more harmful compared to pear obesity because it is associated with increase in visceral fat. Now, the cafeteria of contraceptive choices are intrauterine contraceptive devices, progesterone-only implant, progesterone-only injectables, progesterone-only pill, combined hormone contraception, and emergency contraception. First, coming to intrauterine contraceptive device. Intrauterine contraceptive device is highly effective method of contraception. Its effectiveness is not affected by the body weight or BMI because the mechanism of action is local. It does not depend on the systemic drug levels. It is a safe contraceptive option for women with raised BMI. There is no effect on the weight of the obese patient in case we use IUC. Obese patients are associated with an increased risk of endometrial hyperplasia. While by using IUC as a contraceptive choice, there is a overweight patients or obese patients because of their body habitus, difficulty in visualization of the uterus, and but this does not extrapolate to increased chances of failure or increased chances of expulsion. To improvise, we can use specially designed gynae couches or multiple size of speculums. Coming to progesterone-only implant, Progesterone implant, we have Implanon in India. The etonogestrel implant is a highly effective method of contraception. Its effectiveness is not affected by weight. Although some studies, kinetic studies suggest that the body weight is inversely proportional or there is an inverse relationship between the body weight and the serum ENG levels. But the analysis from the CHOICE project suggests that though the serum levels might be slightly decreased, but this does not lead to it does not amount to a high failure rate because the minimum threshold level of 90 picogram per ml etonogestrel is maintained in the serum. The license duration of ENG implant is of 3 years. It applies to women of all weight categories. ENG implant is safe. WHO category 1, as already described by Dr. Ila, there are different categories. WHO category 1 means it is safe to use. WHO category 2 means it can be used, usable, and WHO category 3 means not recommended. So ENG implant is a safe WHO category 1 contraceptive option for women who are overweight and women with obesity. It is category 2 in cases where obesity coexists with other risk factors for cardiovascular diseases like diabetes, hypertension, and smoking. There is no weight gain associated with the implant. The non-contraceptive benefit of using an implant is it alleviates dysmenorrhea and ovulatory pain. There is no difficulty in placing the implant or removal of the implant. Next, progesterone only injectable. Progesterone, the effectiveness of it comes by the name of DMPA. The effectiveness of DMPA is not affected by the body weight or the BMI. DMPA use appears to be associated with some weight gain, particularly in adolescents less than 18 years of age, with a body mass index of more than equal to 30 kg per meter square. It has been seen that these adolescents, if their body weight increased more than 5% of the baseline within the first 6 months of use of DMPA, then they experience a continued weight gain. So DMPA use is associated with some weight gain in obese patients. Studies neither confirm nor exclude any causal association between DMPA use and venous thromboembolism. While obesity alone does not restrict the use of DMPA, it is WHO category 1. But when DMPA coexists with, when obesity coexists with one of the multiple risk factors like smoking, diabetes, or hypertension, then DMPA use becomes WHO category 3. The health benefit of using progesterone only injectable is it helps in the management of heavy menstrual bleeding, dysmenorrhea, protection against ovarian and endometrial cancer. The practical consideration for using the POI in obese patients is that we can use a longer length needle to reach the gluteal muscle, or we can inject it into deltoid muscle, or we can use a subcutaneous DMPA by the name of Uniject. Progesterone only pill. Progesterone only pill, the effectiveness is not affected by the body weight or the BMI. POP is safe WHO category 1 in patient overweight or obese women, and it is WHO category 2 in where obesity coexists with other risk factors like diabetes, hypertension, and smoking. Double dose of POP for contraception is not recommended for women who are overweight or women with obesity. The non-contraceptive benefit of POP is it helps in alleviation of heavy menstrual bleeding, dysmenorrhea, and premenstrual syndrome symptoms, especially the desogestrel containing POP. Combined hormonal contraception. The effectiveness of combined oral contraception is not affected by BMI, although the imperfect use of some studies suggest that the imperfect use of COC can lead to higher failure rates because some ovarian activity is seen in the hormone-free interval, that is the 7-day period interval. Sometimes in obese patients, the pharmacokinetics of these drugs are altered, so some ovarian activity is seen. So it is of imperfect use, it is there might be some failure rate, otherwise it is equally effective. There is reduction in the effectiveness of patch in women weighing more than equal to 90 kg of body weight. Vaginal ring effectiveness is not affected by the body weight or BMI because it is the drugs are absorbed locally through vaginal mucosa bypassing the first liver past metabolism. CHC use is WHO category 2 for women with BMI more than equal to 30 to 34 kg per meter square, and category 3 for women with morbid obesity, BMI more than 35 kg per meter square. There is no weight gain associated with CHC. Health benefits are it helps in reduction of heavy menstrual bleeding, elevation of premenstrual syndrome, helps to alleviate symptoms of PCOD, reduces the risk of endometrial, ovarian and colorectal cancer. Women with obesity should be informed that obesity or raised BMI per se as well as CHC are both independent risk factors for thrombosis. There is current CHC use is associated with a slight increased risk of VTE. Current CHC use is associated with small increased risk of MI and ischemic stroke. Hence, in patients with BMI more than 35 kg per meter square, CHC use is category 3. That is, it is not recommended. Now, barrier methods and fertility awareness methods. No studies have been done to evaluate the effectiveness of barrier methods. They are prone to user-related contraceptive failure because of imperfect use. Fertility awareness methods are unreliable because patients with obesity suffer with, some of them have irregular cycles, so FAM is not reliable in them. Emergency contraception. Copper IUCD is not affected by the body weight or BMI, hence it is the most effective method of emergency contraception. 1.5 milligram of levonorgestrel emergency contraception appears to be less effective in women with BMI more than equal to 26 kg per meter square or body weight more than equal to 70 kg. Double dose of LNG EC might be used in these patients with a higher BMI more than 26 kg per meter square. The effectiveness of double dose LNG EC is unknown. The studies are still in progress. Now, sterilization, hysteroscopic tubal sterilization scores over laparoscopic tubal sterilization in patients with raised BMI because laparoscopic tubal sterilization is associated with a longer operating time, technical failures, more anesthetic and surgical complications, and morbidities associated with entering the abdominal cavity. Whereas hysteroscopic tubal sterilization is unaffected by BMI and it can be done under local anesthesia. Contraception and weight management. There are weight loss medications and bariatric surgery for the management of weight in obese patients. The different medications like orlistat, naltrexone, different laxatives. The effectiveness of COC, POP and oral emergency contraception is reduced in these patients who are taking weight loss medications because the vomiting and or diarrhea induced by these drugs. As well as these drugs might be associated with teratogenic risk of cleft lip and or palate. So it is advisable to use contraception other than POP, COC and oral EC. Now weight loss surgery, there are different types of weight loss surgeries, restrictive surgeries like banding and sleeve gastrectomy and bypass surgery, malabsorptive surgery. The bariatric surgery has a potential to decrease the OC effectiveness because of surgery per se. It leads to malabsorption as well as post-operative. There are restrictions in eating and drinking, in taking, and there is diet restriction. Surgeons prefer fluid diet and then they go over to solid diet. So it is difficult and they prefer taking medication in the liquid form. They advise the patients to take medication in liquid form. So it is so the effectiveness of oral contraceptives might be decreased in these patients. So it is better we go for a non-oral hormonal contraception in these patients who have undergone bariatric surgery like copper IUD, LNG IUS system, implant, DMPA. They are all WHO category 1 for all BMI categories. Non-oral contraceptives appear to be safe and effective. ACOG recommends that effective contraception is important for 12 to 18 months post-surgery because of, first of all, the obese patients are usually subfertile, and after bariatric surgery, there is a sudden and intensive weight loss. So they from subfertile, they can become fertile. There is ovulation. So they should have some effective contraception plan. Second thing is that post-operatively these patients have a rapid and intensive weight loss, so there is risk of malnourishment to the fetus, and it is associated, pregnancy is associated with increased maternal and fetal complications. Now, women should also be advised to stop CLC and to switch to an alternative effective contraceptive method at least 4 weeks prior to the planned bariatric surgery because of risk of post-operative thromboembolism because of decreased mobility. Bariatric surgery is associated with vitamin D deficiency and hence reduced bone mineral. DMPA use is also associated with a small loss of BMD. Hence, the patient should be informed clearly that use of DMPA and bariatric surgery both are individual risk factors which lead to some loss of BMD, though studies have not suggested that this leads to increase in the risk of fracture or osteoporosis. So at a glance, this is the WHO category for contraceptive used based on the body mass index, which I've already explained in the previous slides. Approaching weight issues in these patients, we should be sensitive, non-judgmental, respectful, and try to take her permission to discuss weight with her and give her the reasons why discussing weight is relevant to choice of contraceptive method. So in conclusion, IUCD is highly effective and safe, but may be associated with difficult insertion, challenging insertion. Implant is highly effective with low failure rate, but availability and cost remain an issue in India. POP is safe and effective, but double dose is not yet recommended. Studies are still in progress. Progesterone only injectable is effective, but associated with some weight gain. CHC use may be associated with slight risk in thrombosis. Thank you so much.
Excellent. Dr. Umarai is there if she wants to make a comment, Dr. Umarai? Madam? We should not hurry up and we should make comments so things become very, very clear. Here I just want to make a comment as far as the last presentation is concerned. As far as BMI is concerned and we Indians are concerned, it is WHO criteria minus 2.5 for every category. For every category. Now, as for the morbid obesity is concerned, I think all of us should be very, very clear about it, that the people who do not have comorbidities, for them it is 35. And people who have comorbidities, it is 32.5. So that particular point must be very, very clear. Gone are the days when the pediatric surgery, liquid therapy was given for a very long time. No, it is just 15 days. Just 15 days. As such, having relationship is a big problem, people who are morbidly obese and coming for pediatric surgery. So you said very rightly that again, in case if their DMPA had been used, they should stop it. But majority of them, they are not using anything of that particular sort. Whenever when the consent is being taken for pediatric surgery, they are taken in writing that they should avoid having a pregnancy for 1 year.
Yes.
Malnutrition does not take place provided they know and they stick to the diet plan given by the surgeons from time to time. It is a very effective thing, and WHO says that earlier than later, the people should go for the pediatric surgery. Otherwise, the points which you said was very relevant.
Thank you.
Madam, can I add one thing?
Yes, yes,
that, we've had cases, we've had 2 cases wherein they spontaneously became pregnant. This was when Arush started to do bariatric surgery, and they were very soon, like just 4 months after bariatric surgery, they'd come with spontaneous pregnancy. So we realized, and we had come to a conclusion that, and we concluded that probably intrauterine device would be the only method that would work for such patients, So that is what we have been doing for such cases. And if anybody would like to say something else, madam, or you could suggest.
See, I think very rightly. As far as the bariatric surgery magic is concerned, I have seen the diabetes disappearing.
Yes.
In a month's
madam,
time.
Yes.
And as far as other comorbidities are concerned, they even a fatty liver, grade 3. After a year or two, once they have weight loss of something like 40 kg, everything reverts back to normal. So what I find it is wonderful, but as far as pregnancy is concerned, in case if the pregnancy occurs within 1 year, all effect of the bariatric surgery will go.
Yeah.
Because the hormonal changes are so much, she's going to put on weight and her things will go down. So it is taken as a consent. मैं जब लेते हैं तो उसमें बताया गया है कि आपको use करना पड़ेगा. And
अब हम यही करते हैं.
हाँ, and very rightly you said that कि आपको उसको effective contraceptive use करने की बात करेंगे. So that is it.
Very good. Excellent presentation. Very good choice.
Dr. Jyoti Aggarwal, you want to make any comment on all 4 presentations? Dr. Mani, I can see Dr. Pushpa Chandra. Dr. Pushpa Chandra, I will like to have, you are one of the very respected private practitioner and still your, consultations are sought for. What will be your contraceptive advice for adolescent girls? Dr. Pushpa Chandra. Madam is not responding.
I think she has not heard, probably.
Anybody wants to make any comment?
Ma'am, I just want to say that adolescent age group and both HIV patients, they must be counseled to use dual contraception. These are 2 groups in which dual contraception is very, very important. Both in adolescent and HIV, especially discordant couples, ma'am.
नहीं बहुत जरूरी है. Double contraceptive for both HIV and for adolescent is must.
Yes.
Because both the things they do not want. They do not want STDs and they do not want pregnancy. Why oral sex has become popular in the Western world? It's all because of this. So this is why we have to tell them that oral आपने pregnancy नहीं चाहिए तो oral contraceptive pill use ही करने पड़ेंगे. और उसके साथ आपको barrier contraceptive भी use करना पड़ेगा.
True.
And जो हमारे हिंदुस्तान में available नहीं उसके बारे में हम बात करेंगे नहीं. I think and what I feel is all people who come with adolescent pregnancy, when you're getting them investigated, who are still not married and having a relationship, please get viral markers done, especially HIV. In Corona time, we have had 2 patients who were HIV positive. After a long time, I got HIV positive in this category of people.
Now, and smoking is another problem that you see in these adolescent girls,
Yes, I think so. I think it had been a great show today. I again apologize, Dr. Seema, for little bad remarks, but this is meant for your things. We are all available for you, for your presentations, because I think it is good to take a little consultation. Because whenever we are talking, any presentation you are talking about, आपकी इतनी लॉन्ग प्रैक्टिस है, आपने जो यूज किया बस आप वही बोलो. किताब में क्या लिखा बाहर में जाने दो. हम लोग सारे अंग्रेजी की किताब पढ़ते हैं, फॉरेन वाले लोगों की बात पढ़ते हैं, हम अपनी बात ही नहीं करते. That's why you misguided.
Okay, ma'am. I'll take care next time.
So I think it had been a great thing. This is your certificate of participation comes to Dr. Seema Gupta. Your earlier presentation had been great, and I again say I'm really sorry for the remark which I have made just now. So congratulations to you again.
Thank you, ma'am.
Praveen, congratulations.
Thank you, ma'am. Thank you so much.
Manju Sharma, congratulations.
Very nice, madam. Excellent topics. Excellent, very well covered.
Very well covered. I think all topics were justice had been done there, and
very good.
very good.
And I have to congratulate you and Dr. Deepti for the choice of topics.
Doctor, I had definitely told the topic, but I forgot about things that they are today and they are, because they are at 3:30. I forgot about this particular thing. I apologize for that. But we definitely want our younger people, because we have to see to it that tomorrow when we are not there, these people are trained well.
Oh yes, madam. You are channelizing all of us, everybody, madam.
I think it was absolutely wonderful.
बहुत मजे का, बहुत अच्छा है, very practical and very well put across. All the speakers were excellent.
Everybody did a good job. Good job.
Very good. Right from Dr. Praveen to Dr. Ila to Dr. all of them, to Dr. Manju Sharma, Dr. Seema.
Thank you so much. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, Dr. Ila. Thank you, Dr.
Congratulations.
Seema. Thank you, Dr. Praveen. Thank you.
Deepti, congratulations.
Thank you, ma'am. Thank you so much.
Thank you, Deepti, for giving me this opportunity. Thank you so much.
ऐसी बातें करते हो. डॉक्टर मंजू कितना बढ़िया बोले. अच्छा, अपने आप को अनम्यूट करो तो.